Hello, Facebook. I am Kanika McNeil, and I'm the East Area Education Director for the Crohn's and Colitis Foundation. I'm also an IBD patient, therefore, I'm extremely excited today to be hosting today's Facebook Live chat. Welcome. April is National Minority Health Month, and to observe, we've been sharing experiences of racial and ethnic minorities living with IBD on our social media accounts. The incidence and prevalence of IBD is increasing among racial and ethnic minorities, and minority patients may experience their disease differently than white patients. To share a little bit more about the impact of IBD on racial and ethnic minorities, today I'm joined by Dr. Eileen Chairbody from Johns Hopkins School of Medicine and IBD patients Brooke Abbott and Tina Ashwani Amprakash. If you're watching the video today, say hi. Comment below, letting us know who you are, where you're from, and ask questions. We'll try to get as many in as we can. So let's get started. First, I wanted to start with Dr. Chairbody. Dr. Chairbody, how prevalent is IBD within racial and ethnic minorities?
Like you just said, this is almost like a new phenomenon. For many years, our patients with IBD all look the same. They were Caucasians from Western Europe or the US or Canada and people of Jewish descent. So most of us are used to seeing these patients, Caucasian and patient of Jewish descent. And most studies have been done in this population. But what we've been seeing now all around the world, there's an increased incidence of IBD in areas where typically we do need to see IBD, but within the US, we're really seeing IBD becoming a problem, a health problem in many minorities. In African Americans, are really the minority where we're seeing the steepest increase in IBD. Of all the new cases of IBD that we have every year, 1/3 of them are now African American. But what's very interesting is that immigrants from other countries, like from India or Hispanics, after the first generation, their risk of having inflammatory bowel disease is becoming the same as the general population here in the US. So we're definitely going to see more and more minorities with IBD. So it's very important to understand that this is happening, and for us physicians to assess patients as possibly having inflammatory bowel disease when they come to us with gastrointestinal or non-GI symptoms.
Okay, and what are some differences in ways minority patients experience IBD?
So there are some studies looking at mainly African American and some studies looking at people from India and Hispanics, and some, looking at different studies, we reach different conclusion. Overall, it seems that patients, minorities, present their inflammatory bowel disease very similar to how Caucasian present. There are a few little differences. For example, what I find it interesting, so immigrant from Hispanic immigrant, first generation, when they come here, they often develop ulcerative colitis later in life. And after the first generation, they develop more Crohn's disease and earlier in life. So there are things that change probably with different environmental factor in how the disease would express itself. We sometimes see more extensive disease, what we call pancolitis in patients with ulcerative colitis if they're Hispanic or from India or Asian. So we see certain differences, but to be honest, it's mainly the main difference that we see are actually due probably not to the ethnicity, but really to the barriers to care that we see in minorities. The delayed diagnosis, the delay in getting appropriate treatment, the delay in being able to get those treatment and maintain those treatment. So what we're seeing is that in minorities, they're often, when they present to the doctor, when they finally get to the physician and get a diagnosis, they often have a more severe disease. They often get their care more in the ER and acute care. They get more hospitalized because their disease is not well controlled. And when they're hospitalized, they stay longer in the hospital. And it seems also from studies that minorities have less access to effective therapy, like biologic, and They get less access to surgery when it's needed. And when they get surgery, they often get more readmission because the follow-up probably is lacking. So what we're really seeing in terms of differences between Caucasian and minorities, how they're presenting with IBD, I think is mainly due to the effect of delayed diagnosis, delayed access to care, and suboptimal care, the consequences of that.
Right, right. Okay. Thank you, Dr. Tirabadi. And so, Brooke, I'm going to move to you. What challenges have you faced as an African American IBD patient?
Well, it kind of comes in different forms. In the beginning, it was misdiagnosis. I had a lot of, oh, you might have lupus or you have this. It was almost as if African American women could not really have ulcerative colitis. So the symptoms that I was talking to the GI about or to the doctor about, apparently I was making them up, or it had to be something else. It was definitely not UC. So for a long time, I was either misdiagnosed or not really paid attention to. And then, are you getting a feedback from me, by the way? No? Okay.
No, sounds good.
Okay. And then there came a little bit of stigma. There's like this subconscious, I don't know how to put this. There's a way that female patients, no matter the color, are treated. And then when you add color or some sort of cultural difference or a language barrier, those particular patients are treated as if they are being dramatic, or they are doubted, they are, or they're not knowledgeable. I've also been treated as a drug-seeking patient, which is very interesting. When I go in talking about pain. So there are just different ways that I have been treated as a patient, but also for myself. I also didn't really see any representation of African-American female patients with ulcerative colitis. I knew some with Crohn's disease, but because I didn't even really know what UC was, and then I didn't know that this was a disease that African-American women could get, I wasn't really active in seeking treatment as well, because I kind of felt like, well, maybe this is, once I did get diagnosed, I was like, well, maybe it's not really UC, maybe it's something else, because I don't really know anyone else. I don't see anyone else that looks like me that's living with this disease. So it was just a kind of an overall walking in a fog, and it's continued to be that way. I was just actually in the ER Sunday night to about early Monday morning. And it's the same hospital I've gone to for years. My surgeon is there, my GI is there, my rheumatologist is there. And the nurses and the physician in the ER doubted everything I was saying about my pain, about the normal treatment that I take, down to where I need to get my IV because I have small veins and I know that my hands work better. That didn't happen. I got poked quite a few times actually until they figured out that maybe they should listen to me. So it's kind of a tumbling fog that continues to follow me with stigma.
Right. And unfortunately, the experience that you recently encountered, it's definitely not an experience that you probably would want to go through ever again. So that I can only imagine that being quite challenging. And so, Tina, what about you? What cultural challenges have you encountered throughout your disease journey?
Sure. So just backtracking a little bit, thank you, Dr. Tirabadi and Brooke, for sharing your experiences. About like some of the barriers to care, I think, and this goes along with some of the cultural challenges that I really faced, is I just want to start with saying that I think there's, this stigma, this taboo surrounding inflammatory bowel disease, and then you add that minority component to it, and there's this whole other level of shame, this whole other nuance, layer, whatever you want to call it, that complicates this disease and the taboos around it that much more. And for me specifically, I can very much relate to Brooke on a lot of levels. the female component, but also the minority component. I think being a woman of color, and especially a woman of a background that does not typically or traditionally present with this disease, and as intensely as I had presented from a very early onset 13 years ago, was very difficult. Doctors would look at me even at some of my sickest points and be like, but you look fine. You look great, especially when I would go for second or third opinions. This happened to me over and over again. It's almost like I wasn't taken seriously because of my background, because nobody could believe that I had such intense disease. And the way that I had to sort of deal with it was by educating myself, by really reading a lot to explain to them the intensity of my symptoms, but also bring to them how intense this disease has been in my family for generations, unfortunately. So that was one of the major barriers for me, but just something that I'm hearing advocating for patients around the world of various skin tones and nationalities, et cetera, is that there is such a huge stigma. And I know Dr. Charabati and Brooke have been talking about this as well. In my culture specifically, it's like we don't talk about anything that represents a flaw. So we will talk about everything but sickness, or everything that it looks pretty on the outside, but really not get into the nitty gritty of what some of our issues are. And when it comes to inflammatory bowel disease, this is so shameful because it is a bowel disease, number one, and because there are so many mental health components around it. This is already so taboo to begin with. Then you add the mental health layer to it. You add the possibility of needing a stoma, ostomy surgery, or various colorectal surgeries and fistulizing disease. And it's like, oh my God, how can you be talking about that? So for a lot of patients, including my father and including a lot of patients that I've been speaking to around the world, even taking that first step by going to the doctor and explaining your symptoms is so shameful. We are just so not accustomed to talking about these things that we're often seeing what Dr. Charabati described as patients being diagnosed much later on as their prognosis worsens and getting treatment much later on because it's so difficult to talk about.
I mean, to piggyback off that, I think for so long, people of color in this country have had to take care of themselves when it comes to medicine. So generationally, you just kind of figure it out, right? And I know, Tina, you and I have had this discussion where you feel, like you said, you don't really talk about it, but there's also this external strength that you have to constantly put on. You always have to be the best that you can be at all times. So being sick is almost like, it's not necessarily a weakness. It's like almost just devastating to outwardly show that you're sick. But then when you go into the hospital and you don't show that you're sick or you're not doing that, it's like you're, no one believes you. It's a double-edged sword for sure.
Exactly.
Right. And so for Brooke and Tina, based on what you've experienced through diagnosis and even current treatment that you receive, how has this impacted your perspective on the disease? Has it changed it? Has it helped? How has it impacted your perspective?
Brooke, you want to go first, or? Okay.
No, you go ahead and sit on that. I'm sorry, I was looking at the dog. Got distracted for a second.
I think the impact for me has been extremely profound. And I can't say this lightly at all. My culture, and really a lot of cultures around the world, I think, have their own traditional forms of medicine. And for someone like me, that meant that from a very early onset of disease, my family and society at large had, really encouraged me to consider those traditional forms, whether it was Ayurveda or homeopathy, naturopathy, Chinese medicine even. And I've tried everything under the sun. And I just want to emphasize this, and not slightly, is that during this time when I was trying this, it was a period of 6 or 7 months, I lost 50 pounds mind you, I was going through therapy as well, and I had this whole fail first requirement from my insurance company. But in that time period, I lost 50 pounds. I was being fed by PICC lines, and the hair on my head was graying at the age of 24. And I went in for emergency colorectal surgery to have my colon removed. And my surgeon and his chief told me that they were not sure that they'd be able to save me. And this is an issue that I can't emphasize enough, is that I've seen throughout, the world, that a lot of people rely heavily on these medications. And I don't want to sit there and judge that, but at the same time, I want to spread my own experience, which has not been so great. There's a reason why modern medicine exists, and there's a reason why the Food and Drug Administration, as well as the European Union, have introduced and approved biological agents as well as immunosuppressing medications. And I'm sure Dr. Chakrabarti can speak to this more greatly. But as far as culture goes, that's been extremely impactful towards me. I've seen the deleterious effects of it, and I always encourage patients to sit down with their families and with their practitioners to make shared decisions, the best decisions for their care.
I think Brooke and Tina really summarized many barriers to care that a lot of patients with IBD face, and maybe more in particular in minorities. You have, unfortunately, in this country, we have around 25% of African American and Hispanic are on poverty line. So when you have a low socioeconomic status, it's hard to get care. You might not have insurance. You might have a not so good insurance where you have a high copay. You might have a job where, if you take time off to go see the doctor or get a test, you might lose your job. So there's a lot of financial constraint and fear of losing your source of income if you go see the physician, if you have a disease, if you need to go for treatment. So all this really plays a role. Barrier language, both ways. You might not be able to express what's going on, and the physician might not understand well. And to be honest, in terms of physician attitude, there might be some unconscious bias there, where if a patient is not understanding what you're telling them, you might go through the visit faster. You might, not go through details about the diagnosis, what it means, and the treatment when there's a barrier or cultural difference, because you're just not communicating, you're not seeing eye to eye. This part of it, what we call health literacy, meaning understanding the medical term and what's going on. And that's very important. And a lot of patients, whether minority or not, but even more in minorities, have difficulty understanding what we as physicians are trying to say, because IBD is a very complex disease. You're suddenly dropping the bomb of a diagnosis that's complex, that's a chronic illness with a complex treatment, approach. So it takes a lot of patience from the physician, and it takes also, an attitude of really being receptive from the patient. And when, in your culture, in your religion, in your background, there's a lot of, shame, fear, distrust, mistrust to westernized medicine, all this really blurs things and make communication very difficult. And, talking about, what Tina was touching upon, we see that with a lot of IBD patients, because we live in a world now where we're talking a lot about natural things and natural living and healthy living. And all this is important in taking care of any chronic illness and an IBD, in addition to medical treatment. And there is a lot of reluctance in taking medication that we recommend, and more so in minorities, because often minorities come from a culture where there's a distrust of medicine. There's a lot of almost superstitious feel about the disease. That's maybe something coming from God, and if you take good care of yourself and de-stress and eat healthy, you're going to be fine. A lot of traditional medicine, and what all this leads to is a delay in starting the right treatment. And the more we wait, the more we're accumulating the risk of having new complication, of needing surgery, of needing to be in the hospital. And we know from many studies that starting treatment early is more effective than starting treatment late. And all I can say, this is what I discuss with my patient, is that anytime a drug is approved for treating IBD, it's been in the works for many years of research in the lab, animal data, then human data, and drugs never get approved just on one study. There are many studies showing that it's effective and safe to take in this disease, and that's why we recommend it. Now, in a lot of cultures, and this is something, I'm Middle Eastern, so I've seen that in my upbringing. There's a more of a paternalistic way of taking care of patients, where the physician come and say, well, this is a drug you have to take and you're going to be just fine. There's a lot of cultures or countries where there's no real discussion about risk and benefit. So then what happened is, if I have somebody coming from the Middle East or from India, and I discuss with them very openly and honestly, because patients need to know what are the potential side effects of the drug. When I discuss potential side effect of the drug, there's big anxiety and fear that comes out, because this is not something that culturally has been kind of part of the way decisions about medical care is done. So, so for us physicians, it's important when we're approaching a patient coming from a different ethnic background, different religious background, or from a different country, to understand that we might need to talk to these patients differently and approach things not in a dishonest way. We're still going to go over the benefit and the risk, but really put it in a different context, and maybe in a way that is more culturally adapted, because it can be really a big culture shock and really drive patients away from taking the right treatment.
I think sometimes, even though it can get exhausting, it ends up being a constant educational lesson. My family is predominantly Creole from the South, so all we do is eat. That's literally everything is a party, and we always have food. We talk about food while we're eating food. Like, it is very serious. So to go to a big family gathering and say things like, and look at the table and say, okay, well, I'll take, this, and then I'll try and pick the bell pepper out and, go to that, and I'll try to, it, without offending my family, it is a constant speech and a constant talk, and trying to navigate how to keep my cultural integrity kind of, and still be healthy. Because there are things, I have a cousin who has Crohn's, and she and I, the way that we digest things, I have a J pouch now, the way that we digest things are completely different. And so my family got used to that. And then I came along and had something different, and then had surgery and had something completely different again. And now everybody's trying to navigate that. And I'm very fortunate to have a family that will initially say, like, okay, well, is this gumbo, UC friendly? It's friendly for me. It may not be friendly for someone else. And so that's the constant conversation, but also just trying to bring in my own culture into, like, mix my disease into my culture. And that's the hard part. And that's also the conversation that I had to have with my doctor. Now, I'm very fortunate to have a doctor who's from Iran, who really understands having that cultural need, that need to mix your family's culture in your everyday life with your disease. He totally gets that. But having to have that conversation as a minority patient is important. And that's probably something that you need to go in with a list. You have to say, like, hey, Christmas is coming up. This is what we usually do. And this is what my stress level is going to be. This is what my children have going on. This is what we're probably going to eat. This is how much I'm going to travel. Like, how do you help me live my best life in this situation? And that's a difficult conversation to have, because you go in there being vulnerable, and you go in there feeling like less than. There were for a very long time within my family, even though my family's super supportive, I felt very, like, distant and very alone in a room full of people who loved me and were trying to figure it out. And I was in my own way trying to figure it out and isolating myself. So the best thing I think anyone can do as a person of color in any culture is include your family and friends, and include your culture in your diagnosis. And your whole medical team with that too.
And just
So,
to piggyback, sorry.
no, go ahead, Tina.
Add a couple things. Yeah, I can very much relate to Brooke. I think the food and drink aspect are huge. And being both South Asian and American, you integrate the American aspects too. So, like, we'll celebrate Thanksgiving too, but we'll have Indian foods there. And as you know, it's so spicy, it could rip the paint off the walls.
Right.
It's always been that I want to respect my culture, but I want to respect my body as well. And alcohol sets me off too. So it's how do I partake in that merrymaking, be at my sister's wedding or at baby showers or at cultural events or, Thanksgiving or Christmas without, losing my health. And I think Brooke brings up a really good point. It is something that I do speak to my doctor, who's also South Asian American, and who really gets, some of the aspects of the food and the culture and how to integrate all of that into our treatment plan. So I think that's a very good point, and I think that is one of, the tips that I would share for minority patients as well.
Right. And so I see a few people are commenting on the left. No questions yet. So I want to encourage people to definitely ask questions. I see a few comments. Tina, someone's mentioning you in one of the comments, saying that they were just telling you Passover is a 4-hour meal. I'm not sure who that is.
I know who it is.
Okay. So I encourage people to definitely ask questions. But so yes, Tina, Brooke, really great tips. Any other tips on how minority patients should really work with their physicians on, ensuring that they get the proper care and really understanding minority patients? And then Dr. Cherabati, I do have a question for you after this as well.
Well, I'll let Tina and Brooke talk about patient side, but for me as a physician, I want my patient not to be shy. Don't be shy. Tell us what's going on. Tell us everything. We're poop doctors, okay? Nothing is bad enough, okay? We deal with poop. We've seen diseases. That's what my kids call me at home. So nothing is embarrassing. Tell us what's going on. Tell us the symptoms you're having. We were talking about how if you're a minority and a woman, that's maybe the worst case scenario. There's so many diseases showing that women and minorities, they don't get the right amount of care. They don't get evaluated like Caucasian male. But what we need to do is stop that. And one of the way of stopping that is for patient to bring up their issues. So I need to know if you're passing gas through the vagina, if you're peeing blood, if you're peeing stool, if you're having severe pain. I want to know all the physical symptoms. Share with your doctor. We're here to help. And then go beyond that. We are there to help you, not just in terms of the physical illness, but also to help guide you in how this physical illness is affecting your life. If you are, I always ask my patient, but sometimes a physician might not ask you. Tell them you're feeling anxious when you're leaving the house. Tell them you're not feeling yourself. You're feeling depressed. You're worried about getting emotionally attached to somebody or having a relationship with somebody because everything's going on because of the body image, because then we can guide you to the right person to help you. Because inflammatory bowel disease is a physical disease, an emotional disease, a social disease. There's so many things. And the more you tell your doctor, it really gives us a sense of how bad the disease is affecting your life and how to better treat you. If you have 3 bowel movements per day, but you cannot leave the house because of that, we need to, tackle it quickly. So all this is important. So don't be shy. Talk to your doctors. Get involved in patient advocacy groups and in reliable source of information like the Crohn's and Colitis Foundation. This is really, IBD is a disease where you keep on learning. Us physicians, we're always learning. We still learn about this disease. We still don't understand everything. So as a patient also, take that step where you get your source of information from reliable places where it's honest, open, scientific data being shared, whether with patient advocate group, with Crohn's and Colitis Foundation. So get involved so you understand better what's going on. And also so that you're not alone. Again, I don't remember if Tina or Brooke were talking about that, if you don't know anybody like you has this disease, you think it's just something is off. But when you see other people like you who've had the disease, who've been through a certain experience, and who want to help you not go through the bad stuff and go straight to the good stuff, which, and living better, get connected with these patients. Very empowering to see that, women like Brooks and Tina, despite going through all this, like, challenges of the disease, are these wonderful people with, a family life, with a personal life, with advocacy life. So it gives hope. It's very empowering, but also you can connect with people who look like you in a better way and who understand your background, and you can share tips and share things that really help you manage the disease. If you don't find that community in your household, in your family, because there's still a lot of confusion about the disease or other feelings surrounding it, find a community outside your family that can be supportive. So we're all here to help, but just in terms of me as a physician, I want my patient to tell me what's going on so I know how to take good care of them.
I think that, just having grown up in Los Angeles, having the mom who used to shove wheatgrass down our throats, and then suddenly suddenly coming up with a bowel disease that I thought was restricted to my bowel. I initially didn't talk to my doctor very much about my life. And I also just had this innate, I guess maybe it was a distrust or discomfort with having to give more information than he actually asked for initially. He would ask questions and I'd give him, a 1-2 answer, and that was it. And I found that the treatment that he was prescribing for me wasn't working. I was on a medication for a long time that was making me very nauseous and very tired. And even though it was kind of working for my symptoms, it was really taking away from my life. I was not an active mother. I was not really living my best life. And until I was actually open and talking about all the things that I did, how I traveled, what events I had going on, how I felt as a person and as a woman, having swelling up and all of these things, until I was really open with my doctor, my whole life didn't change. Like all my symptoms, everything just did not change. For a long time, I wasn't even seeing a rheumatologist. Come to find out, I needed one really badly, but I didn't think that was something that I needed to share with my GI. So it's very important to share your whole life experience with your GI, to have an open conversation. Don't be afraid. I've introduced my son to my whole medical team so that he's comfortable. And as he grows up, he will be comfortable enough to talk to his doctors about what's going on with him, regardless of what kind of disease or anything that comes up. He'll have that comfort. And so I think it's time for us as the new generation of patients of color to really grab the reins and flip the script and start to make changes with the next generation so that we don't keep having these issues, so that the healthcare world sees us differently and we see the healthcare world differently. And I also just want to quickly say, I see all of these reactions and people participating, and they're all from different backgrounds and different cultures. And I think that's fantastic. I think that it's important for people not of color to recognize that the only reason why there's a National Minority Health Awareness Month is because minority health was not being looked after properly and as equally as it should have been. And so until we really hone in on this problem and fix the problem, it's going to affect everyone, and no patients will be really getting the best treatment and the best health care that they can be receiving. And so I think it's so important that we all take a moment to really understand how this disease affects people of different backgrounds, economically, different backgrounds culturally, different backgrounds gender-wise, and everything, so that we can really understand how to tackle this disease as a whole. And I think it's just fantastic that the Crohn's and Colitis Foundation has done this. we're really working on trying to make that happen over at my own advocacy brands, and hopefully people will feel more comfortable in talking and not feel so ashamed of having this disease, and being open and sharing.
And just to add to that, I think there's a few different things. If I were to lay out a few tips, definitely read and stay abreast of the latest research. I think that's helped me basically advocate for myself and my own care as a woman of color. But in addition to that, there's so many other nuances to this that I haven't even gone into. For instance, I was discouraged from ostomy surgery because I was told at 24 no one's going to marry me. And I did get married to the man that I was dating at the time. And I want to impart a message, to the world full of racial and ethnic and sexual minorities, is that we can live full lives with these diseases. We need to have that partnership with our families and with our physicians, with our mental health care providers, et cetera, to help us really come to terms with the illness, accept it, get the treatment that we need, and rise above the shame or the stigmas, the taboos that might exist. I think that the people who really love and care for us will see through all of that. And things like our body image or having an ostomy or having fistulizing disease will matter less and less as people continue to talk about this, advocate for themselves, and as we continue to normalize the conversation and rhetoric around these diseases. I think it's so, so important for us as minorities to continue to speak about this in order to normalize that conversation, and in order for the world to really accept what inflammatory bowel disease is and what sort of aspects of care come with it. And I think our doctors and our families and friend circles are so, so important. And I always encourage patients to go to support groups, and if they are minorities, to engage with other minorities. I think that was something that was missing for me. I went to support groups, really didn't engage with anybody of a minority background until I started advocating for myself online. And I think a lot of people reached out and were appreciative of the fact that there was somebody who looked like them talking about some of our cultural challenges. And I really just want to impart that message that we can live fuller lives with these diseases, that we have to have this partnership, and that I really thank, my community, my tribe, my doctors, as well as the Crohn's and Colitis Foundation and my family for bringing me to the point where I am to help advocate for other patients like myself.
Great. And so in closing, I wanted to ask Dr. Chairbody, I know you talked a little bit around what patients can really do, right? Be honest, share your experiences, let their physicians and gastroenterologists know what's going on with their disease and how they're feeling. But what can how can physicians actually become more equipped to work with minority patients? What suggestions do you have for that?
So I think, first of all, as physicians, we need to be aware that IBD exists and exists well in minorities. So, the fact that when patients present with GI or joint pain or eye inflammation, we don't think about IBD because they're from India or African American or Asian. That is wrong. This is the past. The patients that we're seeing are not all Caucasian anymore. We're seeing a diverse population, and IBD is on the rise in minorities. So one is recognize that IBD is present in minority. And that's one of the reasons also, Brooke and Tina, we were talking about how important it is for minorities with IBD to speak about IBD, because other patients can recognize themselves, it raises awareness, but also it raises awareness for physicians. So when you're doing your advocacy work as physicians who might not be super involved with IBD, general GI, they're realizing also that IBD can exist in minorities. So that's one. Two, there's the unconscious bias that we need to work on. And this is something that Brooke was talking about and Tina, is that, there is even the best people in the world that mean, really well. there is a implicit bias that so an attitude toward people who are different than ourselves, and certain prejudice. So whether it's ethnicity, religious background, gender, sexual orientation, physical or mental handicap, when people that don't look like us or what we used to take care of show up in our clinic or in our hospital, there is a certain unconscious prejudice, and we might not take seriously their symptoms or do the right test or start the right treatment. So it's very important for us physicians, all of us, to work on that, to recognize it and to be willing to work on that. And this is a big topic of discussion. And at DDW, the HEA Diversity Committee is going to discuss that, because it's very important to accept that this is what it is, and that we need to work on that. And not just in terms of just the physician, but the whole medical staff, the receptionist, the nurse, everybody's attitude need to be different in terms of taking care of people that are different than themselves. So that's the second thing. And then the third thing is really to realize that when people come with their illness and their symptoms, it's not just that. There's a whole cultural, religious, family background that comes with them. And if we don't realize that, we're going to approach the patient completely wrong. We're going to get offended that people are not understanding what we're talking about, that the family's being difficult, that patient are not following up or showing up, and we're going to label patients as being non-compliant or difficult, or all kind of labels that are negative labels that we should not be using. We should really figure out why the patient is having this attitude or these questions or these concerns. So physicians need to be aware of that not everybody's coming from the same background. Not everybody is willing to have conversation the same way. And by being really prepared on how to talk to somebody coming from the Middle East, how to talk to somebody from a different religious background, how to talk to somebody who's from India or Creole, etc. All this is different, and really approach it with a cultural sensitivity, if you want, that can really help you connect with the patient and really show the patient that you care about their culture and their value, but also you care for them as a person, and you're trying to give them back this life. You're trying to treat them so that they can enjoy their culture and enjoy their tradition and enjoy their family life. You're not trying to go against their culture, but really work with it. So there's a lot of work to be done. And, it's interesting that both Tina and Brooke talk about that their physician comes also from a different background. And so there are a lot of similarities, but, we can't ask every patient to go look for a physician that look like them, or they come from the country they're coming from, or, but sometimes it might come to that. If you as a patient or as a physician feel that you're not providing the right care for the patient, or you're not the perfect, kind of match, there are certain culture where there's a lot of big, for men being, strong and macho, and maybe, confiding in a female physician about, the GI symptom and the incontinence and the difficulty, that might be add a layer of anxiety and difficulty. And maybe if I can sense that, maybe I can refer to a male colleague, right? Or somebody else that would, be more compatible. So it's important to be open to that, realize that, and try to work with patients and their families. And, I have a lot of discussion with families when I'm taking care of IBD patients, but I feel this happen even more with certain minorities or ethnic background, because I feel that I talk to my patients go home, and then the mom, the dad, the grandfather, the grandmother, the uncles, the aunts calling from somewhere else is going to make their opinion and make them change their mind about the treatment plan that we had in place, because they're going to impact that. So for me, I'm like, next time, come back with your family. I want to talk to them. They need to hear from me. So as physicians, we really need to take some time, that extra step, and kind of engage the family and try to break those barriers and that distrust and the prejudice and everything else going on, and really build that trust even more with minorities. But I mean, we do this for all our chronic illness and IBD patients, but even more with minorities coming with a lot of, different sense of what an illness is. So we need to put that extra effort.
Yeah, no, I think that's great. And I think Tina and Brooke both kind of touched on that aspect, what it means to really interact with your family with this disease, and them having a true understanding, and some of the stigma that might be around it. So no, Dr. Cherabati, that's fantastic. And we do have a question. Any idea, and I think you touched on this briefly in the beginning, any idea about the number of Caucasian versus all minorities diagnosed with IBD?
So that's a very good question. So it really depends on the source. We think that there are overall 2.2 to maybe 3.5 million people in the US with IBD. And like I said, in terms of like new diagnosis of IBD every year, 1/3 are African American. One of the reasons why this number goes from 2 million to more than 3.5 million, because it really depends on whether it's a study, whether it's self-reported, whether it's a diagnosis from physician billing. Because again, a lot of patients might not be seeking care, and I think there's a lot of IBD floating around undiagnosed, so it's difficult to have a specific number. But what we're seeing definitely is that the incidence of IBD in minority is steadily increasing to reach that of Caucasians.
Mm-hmm.
Okay. And I'd also just kind of piggyback on that. I've sat on a few ad boards where we've put these wonderful surveys together to try and figure out where the discrepancies are in medicine throughout the country. And what we're finding is that there's a low amount of people replying of color. And I know just from my own background, a lot of Black folks just don't fill out surveys. So I mean, it's true. I will push them. Nobody responds. I am asking and I am encouraging all people of color watching this. If there is a survey that goes out from the Crohn's and Colitis Foundation, from the CDC, the NIH, some sort of reputable source that is trying to figure out, and the reason why, I know there's like a lot of, hesitation there, but this will help with research and development and in order to figure out who's sick, how they're getting sick, how they can be treated, because at the end of the day, the disease does attack us all differently. And sometimes culturally, it can kind of move in clusters. So please fill out those surveys. Please let them know that you are of color, what your culture is. It is very, very, very important. The last survey I think I sat on a board for, it was predominantly Caucasian, and I think it was like 2% African American. And I saw where they were sending it out, and they sent it out in a way that African American people did see it, but they just didn't click on it. So I'm just encouraging everyone of color, when you see it go out, please fill it out. It is very important. And the information, stays, it's confidential. So.
Great comment, Brooke. So in closing, why would you say that it's important for minorities to really share their experiences with IBD? I know that Tina, Brooke, you've shared yours. Dr. Cherabati, you've talked from a gastroenterologist and physician perspective. But why is it important for African Americans and minorities to really share their experience?
I think, from my angle, it's really to destigmatize the disease. I think that for a lot of us, we don't want to talk about poop, and then to add the minority component to it just complicates things even more. Oh, you're not supposed to talk about that. I get told that all the time as an advocate is, oh, Tina, shut up. You're not supposed to talk about that stuff. That's private. But the reality is that just the same way that breast cancer, prostate cancer, other diseases have gotten recognition over the years, I think we need to recognize that Crohn's, ulcerative colitis, colorectal cancer, and the varying degrees of these diseases can really take a toll on people's lives from a very, very young age. And I think just in seeing the last decade or so how much the disease has grown in the South Asian population and even like the Asian population as a whole, I think that it's something that behooves us to create awareness about, to really educate people about, because a lot of us get made fun of. I know I got made fun of left and right, and I hear it from other patients. And I think the education component is really important for us to get the care that we need, to not be ashamed, and to really be partners in our own care.
I think that I hear a lot from people that they feel discriminated against, they feel stigmatized, but all of that is not going to change until people see who the patients actually are. So until we change the language, until we put a face to the disease and make sure that people understand that it can affect anyone and everyone, we're never going to see change. And so if you feel discriminated against, then it is up to you to continue to be vocal and to be vocal in change. Change doesn't happen when people are silent.
Great. Dr. Cherabati, did you have any closing words or final words?
I mean, we can't top that. I mean, Tina and Brooke put it like very nicely that, minorities need to speak up. It helps others. Tina and Brooke, when they were diagnosed, there was nobody around them that looked like them with that disease. And they already been through all these challenges. So it's important for them to speak up and other people to speak up to help others accept the disease, to help others learn about the disease, about the possibility of the disease. Somebody might be watching now and say, you know what, maybe my cousin, that's what they have and nobody thought about it. But really, mainly to take that taboo out of it, to say it's okay to talk about these things. So when it's okay to talk about these things, I can talk about it to my doctor. I can talk about it to my community. It's okay to talk about it with my partner or my spouse, and it's okay. It's the same way, like you said, we talk about other diseases, and for some reason, because it's connected to the digestive tract, but also because it really can disfigure people in terms of, when you have fistulas, when you have surgery, when you have skin disease from IBD, it really affects people. But the more we talk about it, the more we normalize that it's okay to talk about it, and then it's okay to get treated, and it's okay to go through this together, and it's okay to be part of the solution. And again, like Brooke was saying, you have to be involved, and you have to show that there are minorities with IBD, so that we can focus more research and look at more the particularities of IBD in minorities, which treatment would work for them, which might not work for them. What is their specific presentation? What are the things that put them at risk of the disease? How is the environment impact them differently than Caucasians? So it's important, and it's important to spread the word for patients, but also for physicians. Like I said, that minorities can have IBD, and we need to be aware of that when we need to treat that, and we need to be sensitive to the cultural, religious, and ethnic particularities of different minorities.
Great. And just from a patient perspective, from me, which I haven't talked much about, but I know when I was first diagnosed about 17 years ago, I didn't want anyone to know. My mother and father knew, but even I didn't want to share with my friends, even my brother and sister, I didn't want them to know, just because it was considered embarrassing for me. However, I will tell you, a couple years after being diagnosed, just opening up was therapeutic for me, but also so many people since then have come to me and said, wow, I was diagnosed with Crohn's disease or colitis. And they've shared their experiences, and they've wanted me to help them and to help them get through it. And specifically African Americans, because they, one, weren't familiar with the disease. And then also they saw me living with it and saw that we can live normal lives, right? We can do anything that anyone else does. So I also just encourage minority patients to definitely speak up, to share your experience. And it really does make a difference for yourself, but then for also the community. So in closing, that's really all we have for today, the time that we have for today. But I personally want to thank Brooke and Tina and Dr. Cherabati. You all are just absolutely phenomenal and amazing. And I know we allotted a specific time for this for this chat, but it was so great. We just went over.
I think we can all talk forever.
Right.
We could go on forever about this.
Right. So I appreciate all of the time that you've dedicated, not just today, but really for educating the community on this cause. And so in closing, I would like to say the Crohn's and Colitis Foundation is dedicated to providing support to all IBD patients and developing a greater understanding of the ways IBD impacts racial and ethnic minorities. Last year, we were awarded a grant from the U.S. Centers of Disease Control and Prevention to establish the input study. This 5-year effort will help us estimate the incidence and prevalence of Crohn's and ulcerative colitis, determine whether race and IBD practice volume are associated with patterns of care, and identify targets for interventions to reduce disparities in care and improve outcomes for high-risk patients. So if you are a minority patient with IBD looking for support, we encourage you to check out the series that are available on our website, patient videos, and to keep an eye out for our new Facebook support groups launching in May for minority patients. So again, thank you to Tina, to Dr. Cherabati, to Brooke. You all are simply phenomenal. And in closing, if you have any general questions about IBD, for those out there, we encourage you, don't hesitate to contact us. You can contact the IBD Help Center at info@Crohn'sColitisFoundation.org or 888-MY-GUT-PAIN. Thank you so much. You all have a great day.
Thank you.
Thank you.
Thanks.
Bye.
Bye.
Bye.